I think this gives me a little bit of a lower threshold in my practice to put an Impella in for these patients. I think we overtreat protected PCI and undertreat kind of shock ACS patients. All right. Hello, everybody. Joe Walsh here with MurmurMD. I'm joined by one of our illustrious members of the community, Christian McNeely. Christian, what's up, brother?
Hey, how are you guys? Glad to join.
Awesome. Cool. Well, hey, I wanted to share this case and just get Christian's feedback on it a little bit. We've talked about the danger shock trial a lot on the app. And, I think it's a great trial, but, this was the first patient where I was like, this guy really fits into this trial and it makes a lot of sense in the context of this kind of patient case. So I thought it would be cool to share. And Christian, I'd love to get your feedback on kind of how you manage shock patients. You've been such a great contributor with shock cases and complex PCI cases. So looking forward to getting your opinion on this.
Yeah, absolutely.
So this is the trial. We've seen this before. Chris Brown did a nice overview of this. I was surprised when we did our guideline update. We now have a 2A guideline for Impella in cardiogenic shock. And so I think that's important to understand what the guidelines are reflecting. And just remembering the Kaplan-Meier curves that, we haven't seen a trial of this magnitude in terms of benefit with a hard endpoint like death in a while. I was kind of doing this in most of my cardiogenic shock patients anyway, but I think this gives me a little bit of a lower threshold in my practice to put an Impella in for these patients. I think we overtreat protected PCI and undertreat kind of shock ACS patients. I don't know, Christian, what do you think of that? What's your practice like, and did it change much with this?
Yeah, I think that's fair. I mean, as you said, I think a lot of times guidelines and data lag behind clinical practice. I mean, this trial started maybe a decade or so ago.
Yeah.
Um, I think in many practices, this has already become routine, but to also, I still think there's really in the community hospitals, there's probably still a strong under recognition and under treatment of cardiogenic shock. So I think it probably goes both ways.
I totally agree. And I think there's a lot of, even at institutions, there's a lot of
Hmm.
intra-provider variability. Like everybody's
Correct.
got the interventionalist that won't put an Impella in for anything. And then you've got the one that puts them in for everything. And so I think it's kind of finding a happy medium in terms of what cases you're going to use this for that are really indicated and would benefit the patient. So that's danger shock. So this is a case. So this was, I think, a couple weeks ago. 46-year-old guy, STEMI alert during the day, has obesity, has prior coronary disease. He started having his typical chest pain 4 days prior, and he realized that he was going to need to schedule an angiogram. So this guy schedules an angiogram for 4 days later, and then he goes to Vegas and binges for like 3 days on God knows what and gambles and decides to come to the hospital directly from the airport, from Boise Airport. So it was kind of an interesting call out from the ER when they told me about this guy. And I always ask about vital signs when I have a STEMI, just so I can get a sense what I need to do. And when they gave kind of the report on this guy, his blood pressure was 80/40. He was tachycardic. And I like looking at the chest x-rays too. I think if they have pulmonary edema on chest x-ray, I think it's nice. And I generally try to get BiPAP in the room if they have pulmonary edema, just to mitigate the risk of intubation. And the really concerning part, and I'll usually have someone bird dog this when they come up to the lab, is his presenting troponin was 20,000. And so I think there's a lot of really kind of negative prognostic features about this patient's case outside of his age. And then I think the most concerning is his EKG. So, Christian, looking at this, I saw 3 in V1 and AVR elevation, which really made me think this guy's got something hot in his left main. But I don't know. What would your reaction be to this kind of gestalt of clinical data?
Yeah, I mean, I think you kind of hit the high points. His ECG does look compatible with left main disease. I think another kind of quick thing you think about shock. I don't know how much you use the shock index, but I mean, this guy's shock index is 1.5, right? That's heart rate divided by systolic blood pressure. So, like,
Yeah.
immediately you're like, okay, this guy's almost certainly in shock before you even have a lactate, that sort of stuff.
Tell me more about the shock index. I've actually, there's so many calculators, it's a little bit hard to keep track of them. Like,
Easiest thing, systolic blood pressure heart rate divided by systolic blood pressure.
okay. And what's the criteria?
I mean, higher the worse off.
Okay.
So, I mean, but in general, like anything over 1 is,
It's considered I
concerning
guess
for shock. And then this guy obviously like it doesn't tell you what kind of shock, but in this guy, right, your number 1, 2, and 3 differential is cardiogenic.
yeah, absolutely, absolutely, and he's late presenting, right? I think these late presenters, you always have to have a little bit of a lower threshold to support these later presenters, because in my experience, anecdotally, the late presenters are the ones that really kinda tip over really quick. Um, so this is the presentation. So he comes to the lab, does
And
not
do they
look
check a
good.
point of care lactate?
They did not. We have that in the Cath lab. I think the
Mhm.
kinda the cat was out of the bag, though, once he hit the lab because
Yeah,
he
I just didn't know. I think we've tried to do that in our ER, just institute like a care pathway with like, LFTs, point of care lactate, with anyone who has like, that's the presumptive diagnosis.
I love that, dude, because that gives you their baseline when they come in, and so
Yep.
I think, we all know tracking lactates is very beneficial in terms of outcomes, and you gotta get that lactate down in whatever means necessary, but we often get the lactate after they've kinda crashed and burned a little bit, it's better to get
Mhm.
it at front, so that's a great idea. Um So anyway, he looks bad. I had BiPAP ready. We had Levo ready just so we had some time, prep the Impella. And then these are cases I like to go from the leg. So, we mostly radial, but I think when you're suspicious of shock, I think it's always good just to get, femoral access. I know some people will get radial and then just go on to the femoral for the Impella. I don't know. Did you go femoral generally in your shock patients, Christian?
I typically go radial unless like they're coding. Um,
Mm,
and it's clear that I will need to put an Impella in.
okay,
Because like typically like, I had one last week. I can get radial, I can get the PCI done and going, and then like the fellow can get access femorally
got it.
and get an Impella in. So it's kind of the nice thing about having 2 operators, right? Is that you can kind of be doing 2 things at once. So I will typically go radial unless they're like actually in extremis encoding. I mean, this guy would have been totally reasonable. I may have gone femoral for sure, but
Yeah. And I think, the other thing is like you just put the Impella in up front. I still think it's really helpful to get the angiogram. So,
yeah.
that way at least you know what you're dealing with and you can get a sense of, what the coronary anatomy is and what you're going to need. So while you're putting the Impella, if you need rota, if you need shockwave, you can kind of get that stuff ready and kind of get a sense of what you're going to do once you put them on support. So I got pictures first, and as we suspected from the EKG, pretty nasty. I mean, this guy's 46, isn't it? It's kind of crazy how bad his coronaries are at 46. So, what's your interpretation of this Cath, Christian, other than
Yeah, I mean, this is bad. I've been heavily calcified, severe distal left main disease. I mean, Medina 111. I mean, so
totally?
up front, you're going to need lesion modification. You're going to need mechanical support. I think the questions in my mind now is like, clearly at this point, you're going to, not take many more pictures. I think in someone like this, obviously you want to shoot the right, take a cranial and then get your support in. And not mess around too long.
Yeah, and this is I mean, I think the other thing you see from that you're gonna be in for a long working session here, right? So, like, this is not gonna be a one and done direct stent, primary PCI type STEMI, and so you're and this is another benefit of doing the angiogram up front. You know you're gonna be doing some work, right? And you're gonna have to do bifurcation stenting on a left main, so I think this really tells you you really need to put support in early so that you can just kind of take your time and do it well. And then his right, actually, this thing was really, really, really tight, that mid lesion on the right. So you got Medina 111 left main, you got a tight mid right. You're gonna put an Impella in probably, Christian. What's your kind of coronary PCI strategy? How would you do this?
Yeah. You know, you don't clearly have a culprit like a STEMI, but I think your left main is probably the most attributable.
Totally.
So, um, what I would do is put a CP in. Do a right heart cath up front. I think plus or minus. I don't think there's a wrong answer to doing it, but I do think, right, like you don't want to mess around too long and cause some VT, and then you end up in a bad situation. without support in. So at this point, I would stop, get an Impella in, and then go to work on the left main. Um, I think the question of like complete revascularization versus shock is kind of a difficult one with Impella because like the complete trial, right? We didn't those people weren't routinely unloaded with CPs. So I still think the data is valid, but like for this guy, I would probably just do the left main um, with the Impella, let him cool off, do a right heart cath, see what numbers are, see if we need to keep it in for a day or two, and then do the right later on. I think would be my approach.
Yeah, I think
It's
that's
also
totally
heavily
reasonable.
calcified, and you're going to need probably atherectomy as well. Maybe, probably. I mean, it's short, it's focal. You may be able to do a Boolean lithotripsy based strategy, but
Yeah. Yeah, I wanted the quick win, so I went in. I'm like, I'm just gonna fix that right. I'm gonna get a win. I'm gonna like get started because I knew the left main was gonna be a bear. So I kind of wanted to get some perfusion of that right. I figured it would be something safe
yeah,
to start with. And the guy's young, and I always get into this with like heart failure where you leave the Impella in. They're like, well, maybe if we fix the right, we can get the Impella out. And so I'm like, I'll just fix all this stuff today. His kidneys
sure.
fortunately were normal. So
Yeah, I think that's another important thing.
and then, what's your strategy for these heavily calcified lesions? Do you do provisional? We kind of talked about this a little bit, but do you do provisional NC high pressure? And if you get good expansion, you're good. Or do you feel like in a case like this, you would atherectomize up front or shockwave up
For the
front?
right,
Yeah,
For the right, I mean, it's pretty focal. It's heavily calcified, obviously, but by angiography, I would probably start with a microcatheter, a hydrophilic wire, swap for a support wire, get a small
totally.
balloon, a 2.5, something like that, a 3.0, kind of undersized, right? Not 1 to 1, and then image and see what you need to modify. If like your small balloon doesn't go, then, you take your microcatheter back across and swap for atherectomy. I think the other nice thing about a microcatheter is that, like, if you can barely get your microcatheter across,
Totally.
then I'm probably just going to swap for a rotowire.
People perseverate so much about Rhoda, and like I think it's really simple. And every CTO operator tells me the same thing. They're like, if your gear doesn't deliver, you need a Rhoda. Like it's just that's not that complicated, right? If you can't get a
Yeah,
microcatheter across, or you're struggling to get a microcatheter across, you need a Rhoda, straight up, like no question. So I
yeah. So I think
totally
the
yeah.
micro is a good litmus test for that.
What are you using? Because one of my partners is a Mamba Flex person. I started using that, and I really really like it. What are you still
Yeah, it's
Corsair?
a nice microcatheter. I would say I have the luxury of being at a place where we have every microcatheter on the market, pretty much. Um, I like many of them, and I don't want to be too agnostic about brands, but the Mama Flex is a nice microcatheter. It has unlimited torquing profile,
Yeah.
so I do like it for heavily calcified lesions. And the tip is very like the fibers go all the way to the tip, so you can really torque the crap out of it, and it's nice. So I like it. It's a good microcatheter, but there are many good microcatheters that are torqueable on the market. So
Yeah, so that's exactly what I did, what you suggested, and fortunately, it yielded with a NC balloon, and
yeah,
so I just kinda wanted to fix the inflow on this guy. I know there's some distal disease, but, like, I feel like when someone's in shock, you could spend all day on these arteries, so I just really wanted to get the inflow fixed, so I 1 stent, shockwave was ready, but it yielded with an NC balloon, and then
absolutely. There's no way I would go after any of that distal stuff in this setting, or probably ever in a 46-year-old.
get them
Yeah,
off
I
the
think
table,
that's
shock, and then go from there. And then, so I was looking at this. So, what would be your approach to this left main? I mean, there's a lot of different, Culo, Crush. My concern
yeah,
was that both the Circ and the LAD osteally were pretty nasty. So I felt like I didn't want a Culo. That's usually my go-to for left mains. So what would be your approach for this tight left main?
yeah. What's interesting, I think almost looks like after wiring your osteal circumflex almost even looks a little bit better, but maybe it's just there's less streaming.
Yeah.
Um, But I mean, I think, it's never wrong. I think, depending on how the wiring was, I think to try and image and confirm, but to me, I mean, it looks like both ostia are heavily calcified.
Hmm.
Um I think the circumflex is going to be relatively easy to cross with balloons, and the
Mhm.
angle is favorable. I don't know how hard it was to deliver wire the LAD, but if
Surprisingly
it was
easy.
yeah, if it was challenging to wire and get a microcatheter, I would have considered a road up front from left main to LAD. If it was easy, I as it sounds like it was, I think you could definitely deliver a lithotripsy balloon to both limbs. I would probably start with the circumflex. Although you could, the LED may be a little bit it's tighter, but I think it'll probably be easier to. I don't think you'll have difficulty delivering a lithotripsy balloon to both the ostia.
And I gotta be honest, in hindsight, so I ended up just taking a 3.5 NC to both limbs, and I got good
Yeah, and it
experience.
yielded. Yeah,
I
I
kind
think that's
I kinda wish I had lithotripsied a little bit because I did get one area of underexpansion in the LAD, but
yeah.
yeah, I
I think
think
the
when
left main can be unforgiving, and so and a young guy, I feel like I tend to give the benefit of the doubt of trying to be more aggressive with lesion modification.
totally agree, dude. I totally agree, and I do think when someone's in shock and, like, you have the Impella fortunately, he was super stable through the whole procedure, but should that change your approach? I know, like, there's some people that'll do, like, V-stenting when people are in shock just to get them off the table. I don't really think that makes a lot of sense. I think you should approach
Yeah,
it.
I think that's the advantage of support is you can kind of do an appropriate job for you know. I try to not cut corners unless they're really like in extremis and
I totally agree, dude. I totally agree. I think the other benefit of the Impella, and I've seen this too, is that you actually get better coronary flow once you put it in, so you can
yeah,
actually
it's amazing. You get the EDP down.
yeah, yeah. So, pretty straightforward. So, I decided to do a nano crush. I think that's what the kids are calling it these days. I don't know. I think it's just kind of a step crush, but it's like in there a little bit. I was worried about losing the or losing the LAD if I did a crossover into the cert for a culo. So, so put my stent there, crushed it
Why
with the
Nano as opposed? Do you have a 7 French guide?
yes, it's a 7 French guide. That companion sheet's just great. So I usually just use
Yeah,
the
why Nano as opposed to just doing like a mini or a DK where you just had both stents up
I think the
simultaneously?
crush takes forever. I don't know.
Correct.
I felt like it was favorable for this, and so I don't know. Sometimes I'm just kind of thinking on the fly when I do this stuff, but
Yeah, I kind of
yeah.
typically do like a modified mini. It's called gel stent balloon, but it's not that much different. But instead of having a balloon in the left main LED, you have a stent left main LED,
Oh, got
and
it,
then
got it,
the
got it.
stent and the circumflex. It's all different flavors of the same thing.
Yeah, I don't even know what a nano crush is. I just said that to sound smart, Christian. It's honest. I'm joking. I think it's just I think right. Isn't a nano just where you just put it a little bit in the left main, almost like a reverse tap
hmm
kind of? Isn't that's all it is, right?
Yeah, I mean a nano is like right. It's just like you position it at the ostium of the circumflex, and then in a with a 7 French guide and a less step, you can just do it with like a
With a
stents in
stent.
both limbs. But like with a 6 French guide, you kind of need to do balloon in one and then stent in the other.
Yeah, I did crush it with the stent, so I guess that's
Yeah,
technically
yeah.
true. And then, pot, and then I did an FKB, and then it looked fine. Like I said, there was a little bit of
That's
underexposure
great.
on that LAD, but honestly, the guy surprisingly, and like I think this was kind of what really took it home for me. I mean, we took the Impella out on day 3. I decided to leave it in.
hmm
All these folks get a little stunning, especially the late presenters. So took it out on day 3. He was discharged home on day 4. His LV function was pretty normal. I mean, maybe like 50%. And so, I think this is actually a guy that really fits into the danger shock trial. I think the Impella truly did kind of save his life and mitigated
hmm
any organ damage. I'm probably going to have a lower threshold to put Impella in up front. And then, I do think I learned a lot about some risk markers that this guy had that really push you towards using support. But I don't know. Any closing thoughts from this in terms of how to
Yeah.
make this
Did
trial?
you guys ever have a lactate? Was it or like did you put in
Everything
a swan?
I put in a swan. He was peeing like a racehorse. His numbers look good. In my opinion, if someone's peeing, I
Yeah,
worry about lactate and end organ perfusion. So like I really
yeah.
rely a lot on urine output to
It's
confirm
the
the
poor man's swan.
yeah, exactly, exactly. I just that's all I remember from my heart failure rotations is that everyone was always really happy when people were peeing. So I think it's, if your kidneys are getting perfusion, the rest of your body is probably getting perfusion. So So we did not get a lactate,
Yeah,
but
I just
I
didn't know with the day 3 versus, like, taking that is, kind of your de-escalation strategy from I mean, maybe it's just dependent around your schedule,
yeah,
versus
I usually have heart failure see all these people. I think I'm a firm believer that we're really good at managing people in the first day, and then heart failure is better after that. And so I always get heart
Mhm.
failure ward right away, and then I basically just take cues from them in terms of when they think the impella can be weaned, and
Yeah,
they enjoy that stuff and
sure.
weaning all that stuff. So yeah, and then I always remove impellas in the lab, and I'll do usually there's just a radial destination down there just to take a final shot. I just think I worry about laminar thrombus and
Yeah,
vascular
yeah.
complications. So I don't know what's your approach for de-escalation
I
and
think we try to. I mean, I think, following swan numbers is nice. You an echo next day, obviously clearing lactate, CPO. I think those are all things, obviously depending on what you did and what there is left to do. Like this guy, he fixed everything. Um, depending how he looked hemodynamically and how his pulse pressure was with the Impella, like, maybe he could have got her, hard to say. But it sounds great. I think removal wise though, I do think it's good to remove in the lab. I typically don't do radial access. Usually, um, I will just rewire it. If I have a pre-close, I'll tighten it down, put in a 6 French sheath. If that's hemostatic, take a picture with a 6 French sheath.
I love that technique.
Um, and then at that point, it's like a perc angioseal. If it's not hemostatic, I'll put an 8 French sheath. That's not hemostatic, then you got kind of get a problem. But I
Yeah.
haven't had that. Problem. And if
I
there's
love
typically like, yeah,
strategies where you put the 6 French sheath in, then take a picture, and then I mean,
yeah,
I think as long as I think it's important to take a picture just to confirm, and you can use ultrasound. I don't think there's anything wrong with that, but, like, I think it's good to document, if for no other reason than just medical,
yeah,
like, legal stuff, that there was a patent vessel without thrombus that wasn't shut down.
yeah. And we get a lot of patients that get transferred with Impellas in and have been in for a long time, and it is not an uncommon scenario where you take a picture and there's thrombus in the iliac, common femoral, and luckily our vascular surgery colleagues are quite helpful in that regard. So usually, if it's really bad in that scenario, then I usually have them weigh in and we kind of figure out what to do.
Totally. Cool, dude. Well, I think there are
Yeah,
a lot of learning points with this case for me, and I appreciate all of your feedback and stuff like that, so it was really helpful, bud. But thank you for
yeah,
joining today, and hope everybody learned something from this.
yeah. Talk soon, guys. Take care.